Hello, welcome to a brand new medical surgical lesson. My name is Jessie Wheatley and I'll be facilitating this lesson. Please be sure that you have your accompanying notes with you, your textbook ready, and something to write with so that you can follow along with this lesson. Thank you for listening in to this lesson. This lesson is on the RN assessment of the cardiovascular system. This lesson covers a quick overview and review of the anatomy and physiology of the cardiac system. We will focus on assessment methods and the RN diagnostic test assessment and nursing implications for this system. By the end of this lesson, you should be able to understand that cardiovascular assessment is foundation for the planning and implementation of nursing care for cardiac patients. So you're going to have to be really good at cardiac assessment. You're going to have to review the identification of patients at risk and the etiology of increased risk, especially among older adults or anybody in the general populations when you're performing your RN assessment. We're going to review and teach patients the diagnostic tests, whether they be invasive or non-invasive, used in the care of patients with cardiovascular disease. You should be able to develop an understanding of the care of patients before, during, and after any of the diagnostic tests, as well as any implications of the results that are obtained from these tests. In almost every year since the 1900, cardiovascular disease has been the #1 cause of death in the U.S. It's important for the RN, and of particular concern is that cardiovascular disease is the leading cause of death for women. And when diseases or other problems in the cardiovascular system occur, oxygenation and perfusion decrease, and this can be life-threatening. So we'll begin our lesson with an anatomy and physiology review of the heart structure itself. The heart is a fist-sized muscular organ located in the mediastinum, pumps 60 mL with each beat, about 5 mL a minute, adapts to strain and oxygen needs. It's an amazing organ, and it can double its capacity if needed. And the pericardium is what surrounds it, and the septum separates the heart two valves, the atrium and the ventricles. Let's look at the heart structure a little bit closer. We discussed how the two halves of the heart, the right atrium and the right ventricle, are separated by the septum. But here is where the right atrium would look like in an external heart anatomy view. This is how the right atrium would look like in an internal view of the heart. The right atrium gets deoxygenated blood from the superior vena cava and the inferior vena cava both. That's coming from the body and the coronary sinus, the heart muscles. So it pretty much takes all the deoxygenated blood and it goes out through the tricuspid valve. That's what it's gonna get out through. This blood gets out during ventricular diastole or filling. So when filling is happening, the blood's gonna go out to fill the ventricles. And during atrial systole contraction, there's also blood going through there. The pressure of the blood in the right atrium in a healthy adult is about 0.0 to 5 millimeters of mercury. Not much pressure going on in there, but there's pressure gradients being created in there that I want to talk about specifically. Let's talk about the right ventricle. Here is an external view of the right ventricle. Let's go to an internal view of the right ventricle. So there it is, the right ventricle. Its muscular pump, it has enough pressure to close the tricuspid valve above and open the pulmonic valve right trying to get to where you can see the pulmonic valve there, and push blood via the pulmonary artery. So it has enough pressure to close this valve and open that valve so blood can go in. So we have deoxygenated blood that came through the right atrium, and during filling it went in to the right ventricle, and now we know that there's enough pressure created in this muscular pump to push blood right on out. So blood is coming from the lungs, it's oxygenated. It's going to come into the left atrium. There is an external heart anatomy view. Let's go to an internal heart anatomy view. There is the left atrium of the heart. It gets oxygenated blood from 4 pulmonic veins, and blood exits the left atrium through an opened mitral valve. Mitral valve. Okay, we'll talk about valves here in a little bit, and this happens during ventricular diastole. Now, let's talk about the left ventricle. Here is an external anatomy view of the left ventricle. Let's go to an internal anatomy view of the left ventricle. There it is. The left ventricle receives oxygenated blood from the left atrium. When the left ventricle, this ventricle right here, is almost full, the left atrium contracts, pumping more blood into the left ventricle, generating enough pressure to close the mitral valve, to close this mitral valve. Okay, it creates enough pressure to open the aortic valve. Then blood enters the aorta for systemic circulation. The pressure of the blood in the aorta of a healthy adult, compare this to the 0 to 5 millimeters of mercury above in the right atrium, is about 100 to 200 millimeters of mercury. There's a lot of pressure being created in here. Blood is then moving from a high pressure to a low pressure area. The pressure changes control the 4 cardiac valves. So the valves are being controlled by the pressure changes. Let's now talk about AV valves, atrioventricular valves. So we have one right here, tricuspid valve being an example, and mitral valve being another example. So tricuspid and mitral valves are AV valves because they separate the atria from the ventricles. So they separate the atria from the ventricles on either side. Those are going to be AV valves. They are funnels. I call them funnels. These valves are. So imagine a funnel during ventricular diastole. They're letting blood flow out into the ventricles and are closing during systole, preventing regurgitation. So these are amazing valves, the 2 AV valves. So we have tricuspid valve here and we have mitral valve there. The other 2 valves I want to highlight are the semilunar valves. So they're marked here, semilunar valves. They separate the ventricles in connecting vessels. So one semilunar valve, called the pulmonic valve, is between the right ventricle and the pulmonary artery. So the pulmonic semilunar valve is going to be the one that's between the right ventricle and the pulmonary artery. It's going to be the one that opens that way. Okay, the aortic semilunar valve is going to be the one that's between the left ventricle and the aorta. Okay, I hope that review helps you as an RN to look at the heart again. Now, let's talk about coronary blood flow or the coronary arterial system. This is a blood supplier to the heart muscle itself. So what we're talking about here, we're talking about the left main coronary artery, which is marked right here, branching off of the aorta itself. And we have the right coronary artery that's also branching off there. The left coronary artery is going to be where the other coronary arteries are going to branch off, such as the left anterior descending, and the LCX are going to be branching off of that. The right Coronary artery, we're pretty right dominant, most of us, serves the right side of the heart and the inferior wall of the left side of the heart is going to be served by that. Let's quickly talk about the cardiac cycle sequence here. So we have several things happening. It is based on changes in pressure and volume during diastole and systole. So we have diastole is filling time. Filling time. So when you see diastole, ventricular filling, active ventricular filling. 2/3 of the cardiac cycle, the atria and ventricles are relaxed during diastole. So it's filling time. So here is a graphic that kind of shows you what's going on during diastole. Systole is dumping time. So we're going to go into dumping time. I call it dumping time or ventricular contraction time. So there's contraction happening there. Myocardial contraction, what I want you to know, is dependent, very dependent on calcium ions. It's important for a nurse to remember that calcium plays a big role in this sequence, and calcium channel blockers work on these calcium channels. When we're talking about the vascular system, we're talking about the circulatory system here. The vascular system provides a route for blood to travel from the heart to various parts and tissues in the body, carrying cellular waste and stuff to the excretory organs and allowing lymphatic flow to drain tissue fluid back into circulation and returning blood to the heart for recirculation. And blood pressure is regulated by balancing of the sympathetic and parasympathetic nervous system of the autonomic nervous system. 3 mechanisms that I want you to remember when we're talking about this. Number 1, for blood pressure regulation, we have to have an autonomic nervous system which excites or inhibits sympathetic activity in response to impulses from chemoreceptors and the baroreceptors. Number 2, the kidneys. The kidneys sense a change in blood flow and activate our renin and angiotensin aldosterone mechanism. And number 3, the endocrine system. The endocrine system releases various hormones to stimulate the sympathetic nervous system at tissue level. We have to have 3 mechanisms intact to be able to regulate blood pressure effectively. There is a number of physiological changes in the cardiovascular system that are going to happen with advancing age. Many of these changes are a result of loss of cardiac reserve and may not be apparent when the patient is at rest. But when the patient is exerted or doing something physical, that's when you would note some of these changes. You want to make sure as an RN you know how to assess the older adult for cardiovascular changes associated with aging. Your textbook and your notes have listed those out. There's going to be cardiac valves changes, conduction system changes, left ventricular changes, aortic and large artery changes, baroreceptor changes, among other changes in the body. Note that syncope is a transient loss of consciousness that may be common in the older adult. In obtaining patient history, you want to get information on risk factors and symptoms of cardiovascular disease. You want to identify patients that are at risk for cardiovascular disease, especially those at risk for hyperlipidemia, hypertension, excess weight, physical inactivity, smoking, psychological stress, anybody with a positive family history in diabetes. You want to assess the patient's age, gender, ethnic origin, and chronic disease or illness. Postmenopausal women are 2 to 3 times more likely than premenopausal women to have cardiac disease, so the RN should be aware of that. Another great about assessing these patients is you want to be able to tell non-modifiable risk factors. These are things that are uncontrollable, such as for cardiovascular disease, such as age, gender, ethnic background, the family history of CVD. You want to review these with the patient, and you want to make sure that you have educated the patient. A positive family history of coronary artery disease in a first-degree relative is a major risk factor that is more significant than any of the other risk factors we talked about. We also want to talk to the patient about modifiable risk factors. These are factors that the patient can control, such as personal habits, cigarette smoking, physical inactivity, obesity, psychological variables, and we want to make sure that if a patient is smoking, we calculate those, the number of cigarettes smoked daily and the duration of the smoking habit, calculate the pack years. You want to make sure that you obtain a good social history on the patient. If the patient presents with pain, you want to differentiate the pain from angina or MI from other non-cardiac diseases. We want to make sure that it's not just indigestion. You want to talk to them about whether it feels like indigestion, if it's just uncomfortable, if it's squeezing, if it's heavy. They need to be able to describe the chest pain for you. Expand on the description of symptoms. You want to talk to the patient about onset, the duration, the sequence, the frequency, the location, the quality, the intensity, associated symptoms, what precipitates the pain, what aggravates it, what relieves it. Okay, there's a lot you can talk about. Remember that women will often present with a triad of symptoms, including indigestion, abdominal fullness, or chronic fatigue when they're not resting, and it can be of cardiac origin. Dyspnea that is associated with activity is referred to as dyspnea on exertion. You want to assess that. You want to assess the patient for orthopnea that can be seen with advanced cardiac disease. The RN physical assessment is going to begin with the assessment of the appearance, including the journal build, the skin color, and the distress level, the level of consciousness for the patient, whether they're presenting with shortness of breath, their position, and their verbal responses. We want to note any cyanosis. We want to note any jaundice, any Arnosaka, which is generalized edema. Cyanosis is a late sign, and it signals deoxygenated hemoglobin presence in the skin. And these patients in darker skin people may have a grayish color instead of that bluish color that you see. We want to look for a dusky red appearance in the lower extremity, indicating an arterial insufficiency. We want to note any clubbing of the fingers and toes, and signaling chronic oxygen deprivation. We want to note any edema, and we want to chart whether it's pitting and non-pitting, 1+ to 4+. Blood pressure. You want to measure the patient's blood pressure, and we want to note any pulse pressure difference between systolic and diastolic, which reflects cardiac output. Indirectly, though, it is narrowed pulse pressure in heart failure, hypovolemia, shock, and mitral valve regurgitation. We may see a widened pulse pressure in bradycardia, aortic regurgitation, atherosclerotic disease, hypertension, and aging. The textbook talks about ankle brachial index and how to perform that. You can look at that. It is used to assess vascular status in lower extremities. You want to check venous and arterial pulses. Use jugular venous pressure to assess the filling volume and pressure on the right side of the heart. Assess for bruits in the carotid arteries, which are swishing sounds that may develop because of plaque or narrowed vessels. When we talk about the precordium assessment, it involves the inspection, palpation, percussion, and auscultation of the patient's heart. And we're going to listen for S1, which is the closing of the mitral and tricuspid valve, AV valves. It's a low pitched. It's best heard at the apex on the left lower sternal border as indicated in our picture there. You can also palpate the carotid pulse while listening to this. On the EKG, S1 is happening after the QRS complex. We'll talk about that a lot more when we talk about in the next lecture. We know that S1 is a little bit intense when the patient has been exercising or a hypothyroidism case, and mitral valve stenosis makes the S1 intense. It may not be as intense in heart failure and mitral valve regurgitation. If you can't hear the patient's S1, you want to roll them on their left side and then have them lean forward. S2 is another normal heart sound we're going to hear. It is a closing of the aortic and pulmonic valves. The semilunar valves close when S2 is heard. It is a higher pitch sound. It is best heard at the base of the heart. Okay, there may be a paradoxical splitting, which is an abnormal splitting of S2. It may be signals myocardial depression in a patient. I think I've included a few sounds that sound like that in the course that you can actually listen to. S3 is also called a ventricular gallop. It may be normal in people that are less than 30, but anybody over than 30, it may signal early signs of heart failure or a ventricular septal defect. S4 is also called an atrial gallop. It could be due to advanced age and a stiffened ventricle, but it also can be due to hypertension, anemia. Some ventricular hypertrophies cause this. An MI, aortic or pulmonic stenosis, or a PE can cause an S4. Let's talk about murmurs briefly. Murmurs should be noted in your assessment. They're classified by the timing in the cardiac cycle. I've included a lot of resources on murmurs that I want you to make sure that you access. They can happen, murmurs can happen in pre-systole, mid-systole, or a late systole and diastole murmur. Or they can just happen whenever throughout the cardiac cycle. Systolic murmurs are between S1 and S2, may be due to aortic stenosis or mitral valve regurgitation. Diastolic murmurs are between S2 and S1. Those are from mitral stenosis and aortic regurgitation. A pericardial friction rub, it could be a rub heard on auscultation. It's from a pericardial sac, maybe due to inflammation, infection, or infiltration in the pericardium itself in the heart. Let's outline a few labs that we need to be aware of. Blood tests are used to help establish a diagnosis or detect concurrent disease, assess any risk factors, or monitor response to treatment for cardiovascular problems. EBGs may be used to evaluate tissue oxygenation, carbon dioxide removal, and acid-base status in these patients as well. But specifically, I want to talk about serum markers for myocardial damage that you need to know. I've included a reference for you, a chart reference for you in the notes that I want to make sure that you look at. You need to be familiar with troponin, creatinine, kinase, MB, and myoglobin. Abnormally high levels of these proteins or isoenzymes signal cell injury to the heart tissue. Serum lipids, when they're elevated, they kind of signal us to the risk of coronary artery disease. You need to look at the chart that's provided in your notes as a reference and also in your textbook. We may do some x-rays, posterior, anterior, lateral left x-ray views of the chest are routinely obtained to see the size, the silhouette, and the position of the heart. Angiography may be done. You want to assess the patient for allergies to the contrast media or any dyes. Okay, we have cardiac catheterization that is also talked about. This is the most definitive test in the diagnosis of heart disease. The most definitive test is going to be to take the patient to cardiac cath lab. You want to prepare the patient for cardiac catheterization. I've prepared the steps you have to follow, and I've given you a reference in the textbook. Please look at that. EKG provides information about cardiac dysrhythmias or any myocardial ischemia, or the site and extent of an MI or cardiac hypertrophy, or any electrolyte imbalances or effects of any cardiac drugs the patient might be on. We also talk briefly about the electrophysiologic study, which is an invasive procedure during programmed electrical stimulation of the heart that is used to induce and evaluate any levodysrhythmias and conduction abnormalities. You're also going to see your stress test there mentioned, and the drugs that are used in the stress test are mentioned in your notes as well. Tell the patient that these vasodilators are going to cause them to have flushing, headache, dyspnea, and chest tightness for a few minutes after they've had an injection. I also talk about echocardiograms. We talk about TEE, which is an ultrasound with a transducer that is placed in the esophagus to look at the heart function. We also talked about myocardial nuclear perfusion imaging in your notes, MRIs, and electronic beam CTs, or any hemodynamic monitoring. Hemodynamic monitoring will be done in a critical care setting. I have included a reference for you to dig deeper. If you're going to be in a critical care setting this semester, it may be helpful for you to understand the complexities of hemodynamic monitoring. Thank you for listening in to this lesson. I hope you have reviewed the anatomy and physiology of the cardiovascular system and the changes associated with the aging process related to this system. I hope you understand now how to focus on the cardiovascular risk factors. As an RN, you should now be able to better understand diagnostic tests and nursing assessment used to evaluate cardiovascular function. You should be better equipped to review patient teaching and pre- and post-examination nursing care for cardiovascular patients. For any questions about this lesson, please do not hesitate to email me, or if you have any questions about the corresponding notes that come with this lesson, please don't hesitate to email me. Have a wonderful day. Thank you.